All right, very good. So with this one you have to put in order. These are the next two questions are some commonly missed. They're probably the top missed questions for physiological adaptation that I see. And you want to put in order, chronological order, what to do for this patient. So their physiological problem is they got a penetrating chest wound, and there's a rush of air coming out through the trauma site. So they either got stabbed in the chest or something impaled them or rammed them in the chest, and now air is coming out. All right, so what would be the first thing you want to do? So remember, it's an intervention. Interventions are nursing actions. So the first thing that would fix the problem or help this patient or keep them safe, what would be first? Should we do oxygen, put a dressing, blood gas, or pain? All right, very good. Awesome. So if you said two should actually be first. Very good. Two is going to fix the problem. Now, it doesn't really fix the underlying problem that they got this hole in their chest and they're probably going to develop or are developing a pneumo because air is now rushing in through the trauma site. But with the first thing you want to do is do something that helps the patient. So think about your problem. What is the problem? They got stabbed or something went in their chest. I need to cover that site. That's going to prevent more air from rushing in, which is going to create more problems. The more air you get in your chest, the greater the pneumo. But we also want to cover it so that air doesn't go in, but air can come out. So maybe like a 3-window dressing. All right, so that fixes the problem temporarily. It kind of prevents it from getting worse. All right, what's next? I see some fours are being 2-4. What would be next? All right, we got one. Very good. So oxygen. So when you look at these, you have one says, check the blood gas. One says put them on oxygen. They're both dealing with airway, breathing, and circulation. However, the next priority is what else fixes the problem or helps this patient? ABC, airway and breathing, get them on some oxygen because now their lung, their chest area is compromised. And what will the ultimate goal for this patient is to get a chest tube put in. So you're going to begin that setup, get things ready for the doctor to put in the chest tube. All right, good job. All right, then the next thing we're going to do between 3 and 4, you're right, 3 and then 4 should go next. When you look at monitor blood gases, this is also a way to prioritize. Again, you go back to your prioritization, airway, breathing, and circulation. And remember Maslow's hierarchy of needs. Our interventions can be guided by what is the patient's need? What do they need? They need all these things. Well, how do I know what comes first? Prioritize based upon Maslow's. A patient's need or their problem is a part of Maslow's. So first, we're taking care of physical needs. The top physical needs are airway, breathing, and circulation, putting the oxygen on, getting the chest tube. All right, next, you want to go ahead and get the ABG, see where their oxygen is. What is their O2, their PaO2? What is their PCL2? All right, and see if they're going into respiratory failure. Do we need to go ahead and intubate this patient? All right, so that's next. When you look at pain as far as a physical need, pain comes after airway, breathing, and circulation. Monitor just means you're going to assess their blood gas. Whether you interpret it as being you're going to obtain it, somewhere they had to obtain it in order for us to be able to go back and assess it and look at it and see what is it, is it good, is it bad, are they deteriorating? You want to get that before you medicate them, because what if they do need to, we don't want to put a lot of what ifs in it, but what would I want to know before I give pain medicine? I want to know vitals. I want to know how is their blood gas before I medicate them with pain medicine. All right, very good. So great job on that one. For the pneumo, this is just a little clip of some things, some interventions. Collaborative management. Oxygen per nasal cannula, 2 to 5 liters. Position them from optimal ventilation. How would we want to sit someone up for who's having trouble breathing? We want them in semi-Fowler's or a Fowler's position, sitting up. And their good lung, you want down or back. So either just straight up is best. But if we had to do some turning, then if they got, if the bad lung was on the left, I would want their good lung down, because you want them to aerate the bad lung by having it up. So good lung is down. We do want to close the open sucking chest wound with gauze dressing. You want it taped on 3 sides so that air can escape during expiration. So he inhales, but when he exhales, that air can come out, so it's not creating a further pneumo. Prepare for that chest tube. Now, analgesics, they're going to be in pain, but they're going to be in doses adequate to allow the patient to cough, deep breathe as indicated. So I would want to know what, and they didn't mention ABG in here, but according to Maslow's, we want to know that ABG result first.